Good here. Okay, well, good evening, everyone. What I'd like to do is talk a little bit this evening about a little bit of assessment of the acetabulum revision, dealing a little bit with exposure, defect, but just basically looking at various issues. We first must, in evaluating the patient, rule out infection. I think many more infections are present these days. We have to do a sed rate, CRP, and if any of these markers are elevated, I think we have to consider aspiration, doing a synovial cell count for aerobes and anaerobes. I think also we have to identify the components that are in place. You want a previous operative report, understanding which manufacturer has made the device, the size of the shell, whether it's monoblock, type of screws, in order to get access to actually be able to remove a component, certainly if it's malpositioned. Also, we have to know what the femoral component is to be able to change the heads, make sure that you have the right size taper, make sure it's not an off-brand type of component, and also if a lot of these femoral components only have 28 millimeter heads, so you want to have bipolars available in case we want to upsize the femoral head. Intraoperative assessments, we have to make sure. Sometimes if we don't know the component is loose for sure, we have to be able to tap on the cup with a bone tamp from the periphery and make sure there is bone movement or not bone movement. Egress of fluid is also very helpful if we have questions as to whether or not the component is loose from the preoperative radiographs. Our issues in exposure, I believe that a extended trochanteric osteotomy is extremely helpful in certain conditions. But first I would like to mention that a standard posterolateral approach is the most common, and I saw by the audience response that almost 80% of surgeons do a posterolateral approach. I'm not going to go into how we do that. Suffice it to say it has the best access for the to dealing with acetabular surgery. If, however, we do need to do an osteotomy, it can be performed 1 or 3 times before dislocation or after dislocation before the stem is removed, and after dislocation and after stem removal. I'd like to just show one instance, though, since we're dealing mostly with the acetabulum, when we have difficult acetabular exposure, such as this, from multiple previous revisions, when you have severe heterotopic ossification or severe component migration, such as this, you can see the severe amount of heterotopic ossification. What we see here is the ability to go down to the tip of the stem. You can see in the lower photograph, we've done an extended osteotomy down to the stem tip, pulled the stem out, whether it's a cementless or cemented device, and then we're able to remove the component and then dissect around the heterotopic ossification or the severe migrated acetabular component much easier. So I think this is probably the #1 usage of an extended osteotomy for difficult acetabular exposure when we're just doing an isolated acetabular exposure. We always have to rule out infection in dealing with the painful total hip. Even if there's a clear mechanical cause, we still have to take a careful patient history. Wound healing problems at the time of surgery, pain at the since index procedure, fevers, recent illness, night sweats, etc. I think that excellent screening tools are the sed rate and the CRP, as Dr. Duncan was probably the first to really talk about this years ago. And we consider joint aspiration if these sed rates and CRP are positive. So now as we get into this, we've worked this up, and I think we don't want to take any of what I've said for granted. Thinking through this, we have to look at acetabular bone loss. What's important is to determine what type of reconstruction should be considered for each type of defect. What's extremely important is to get the acetabular component fixed on the anterior superior wall and the posterior inferior wall. Both of those pillars have to be present, and if they're not present, they have to be reconstructed, and the other speakers will discuss this. as we look at the acetabulum classification, what I like to look at is the amount of migration superior from the obturator foramina, whether or not there is ischiolysis, and whether or not the teardrop is present, and whether the migration is up and in or up and out. This actually is a typo, should be a 3A defect. We want to see if the migration is up and out. That tells us that the posterior superior wall is absent, and we have to do more of a shelf procedure or a buttress augment. The Kohler's line is intact, which tells us that their anterior superior wall is intact. These up and in defects tell us that we have severe anterior superior wall defect, and that pillar or reconstructive main post will have to be reconstructed. And also we must determine whether or not there's a pelvic discontinuity. We always have to check for this. The other speakers will develop this further, whether or not there is any movement of the top and bottom of the acetabulum independently. So we do a template. We want to take an AP pelvis. We do Judet views, iliac and obturator views, draw a line through the superior obturator foramina, and measure superiorly to see if there's any migration. A type 1 defect, there's no migration, 90% of host bone available. We can see by this x-ray there's little or no migration. Kohler's line is intact. Type 2 defect, which is the most common, there is some migration present, but you can see there's some misshapen of the acetabulum, but the anterior pillar, posterior inferior wall are present. Reconstructive options, gold standard, hemispherical, porous coated cup. As we can see here, there's little or no migration, Kohler's wall intact, posterior wall is intact, and we use a simple press fit cup fixed with screws. And finally, as we get into this, the up and out migration, where there's a migration greater than 3 centimeters up and out, Kohler's line is intact. We have to do a shelf graft. You can see here the options. The other speakers will go into this. Either bone graft can be used, like so, or this is an evaluation of a 12-year follow-up, or finally the type 3B defect, migration up and in, as we mentioned, either reconstructed with an acetabular allograft with a cage, which we've used for many years. But to set the stage for the rest of the speakers, when we have this type of a defect, the use of a cage seemed to work for a period of time, but many of us saw these type of defects fail with a broken cage because of inadequate support and reconstruction of the columns. So we've gone on to use trabecular metal and other forms of column reconstruction, since it appears that this method of reconstruction was somewhat inadequate. So thank you very much for your attention, and we'll field some questions at the appropriate time.
Thank you, Wayne. Excellent overview. There is one question that's been typed in, the joint aspiration information. In addition to the aerobic, anaerobic culture and sensitivity, are there any other values you might think are useful to the surgeon in ruling out infection when you have that fluid sent off for evaluation?
Yes, it appears, and we've been looking at these numbers for probably over 20 years now, and if you have a cell count of greater than 3,000 and a significant shift of PMNs greater than 90%,